Hi everyone, so today's session is going to be on cognitive behavioural therapy for schizophrenia, which is part of the clinical psychology approach in Edexcel A2 psychology. So let's start off by looking at a little bit of background and history of CBT. Cognitive therapy first was developed by Aaron Beck in the 60s. And Beck was quite enthusiastic about some of Freud's psychoanalytic talking cures, but he didn't agree with everything that Freud proposed. For example, he didn't really believe that the idea of the unconscious mind and personal problems were rooted in childhood. He sort of disagreed with that. So what he did was he wanted to obviously propose his own model by using some aspects of Freud. What he particularly believed was that people were capable of understanding themselves and also changing themselves on a conscious level, and all they needed was just a little bit of help. He proposed something called the cognitive triad, and this was the idea that our thoughts and beliefs shape our feelings. So in other words, our behaviour influences the way other people treat us, and then in turn our thoughts and beliefs are also affected. Okay, so it's almost like there is a relationship between thoughts, beliefs and feelings. CBT is a type of therapy that looks at cognitive therapy, so thinking and thought processes, and sort of combines it with learning theories, which obviously aim to change behaviour. CBT has been used alongside other therapies, for example drug therapies, and that is when it's most effective. It can occur in groups or individually as well on a one-to-one session, and it does require quite a few sessions, so at least 20 sessions for some effects to be seen in behaviour. The aim of cognitive therapy really is to change those negative irrational thought processes and to change them into more positive ones. Schizophrenic patients do feel stress along with their symptoms, so CBT would aim to help that individual learn some new coping techniques and strategies such as meditation, so that they can better manage their stress. Beck suggested a lot of behavioural problems do stem from our negative, irrational and faulty thinking, and this was the core of his sort of cognitive triad. For example, if a person thinks that people don't like them, they may feel quite bitter towards and upset towards them. And if they carry on feeling this way, their behaviour will also change to be more defensive. They may become more detached, more cold. And if they started behaving this way towards everybody, then people obviously are not going to like them. So again, the whole link between thoughts, feelings and behaviour in the cognitive triad. People with schizophrenia typically show delusions and hallucinations, which are positive symptoms of schizophrenia. And they're both related to cognitive, irrational, negative thinking. So CBT would help them to make sense and understand their feelings. Delusions and hallucinations can be challenged by the therapist using something called reality testing. And reality testing is when the therapist will devise an experiment of some sort to test whether the client's hallucinations are real. So what they're doing is basically challenging their symptoms. As many schizophrenic symptoms are things like paranoia, where they may believe that other people are trying to get them or plotting against them. So at this point, the patient would be encouraged to try to keep a record of evidence to support this. And evidence can then be discussed in the CBT sessions. So the patient's thoughts are challenged, their negative irrational thought processes are challenged. And another example here is if the client thinks that they have special superpowers, which is a common sort of delusion of grandeur in schizophrenia, the therapist may ask them to demonstrate that power and to try and make them understand actually you don't have that power and it is an irrational power. Schizophrenia is associated with motivational deficits, and often schizophrenic patients will experience things like social withdrawal and anhedonia, which is the lack of enjoyment in any activities which they previously may have done. So the therapist may encourage the patient and reward them for actively taking part in those activities and taking that step to, go back and participate in those activities. The patient is in CBT also given homework, so things that they have to do when they do go home after the sessions. And the aim is really putting the new strategies into action. In the next session, therapists will then review the client's sort of progress and discuss ways of making those strategies more effective. In CBT, often the therapist gets the client to identify something called the activating event. And the activating event is really something that triggers the problem. So in schizophrenia, this might be the delusion or the hallucinations, which can spiral out of control and cause other symptoms. So the client will be encouraged to identify their beliefs about this event. People with schizophrenia, they often hear voices they think are obviously real. And by using things like role playing, what happens when they act on their thoughts, they're really encouraged to think in a more positive way. So together, the therapist and the client will explore the consequence of those beliefs, such as how talking back to those voices might scare other people around them, so it's not acceptable to do that. Ellis, another researcher in this field, also proposed a fourth step, which is dispute. And in this stage, the therapist challenges the client's beliefs and really tries to make them realise actually your thoughts are faulty, and they try to change the client's negative thoughts. So really, during this whole process, the therapist and the client are continuously working together to improve any strategies and coping mechanisms which they have. Here is a link to a short video on cognitive therapy and how it can be used specifically for schizophrenia, so check that out. Next, just going to have a look at some of the evaluation points, so using some supporting studies on this area, on CBT. So let's have a look at some of the sort of other studies that have been carried out. NICE 2014 conducted a meta-analysis. So a meta-analysis is obviously a collection of studies where they'll look in detail and analyse those. And this showed that cognitive therapy was effective at reducing rehospitalizations and also reduced the time that was spent in hospital by 8.26 days, as well as the severity and the symptoms. Generally, psychosocial functioning, so the general functioning well-being also improved. So there's a study there for support which shows that it did help. Another study, McKenna and King done 2014, looked at CBT and compared it with some of the other treatment programs and for schizophrenia, and they found CBT was only effective in 2 out of 9 trials. So what this suggests is that it may not be as effective as some of the other research just suggest, and there will obviously be other therapies that are more effective. In 1997, Kippers found CBT was effective on drug-resistant clients, so those clients for which antipsychotic medication did not work. Those clients did find CBT to be more beneficial for them. Again, what this shows is that it's useful to have another therapy alongside, or cognitive therapy or drug therapy. CBT has been shown to be effective in that it does help to generally improve the patient's life, because they're able to then discuss and talk about their symptoms, and again really encouraged to develop themselves personally and also social skills, which obviously treatments like drug therapy do not do. And many patients with schizophrenia, however, do drop out of cognitive therapy because they do require a lot of commitment and time. Patients do need to be highly motivated and want to see a positive change because it does require effort, which is obviously unlike antipsychotic pills. So a lot of commitment is required. Therefore, the dropout rates are also high, unfortunately. Cognitive therapy is specifically designed to reduce positive symptoms of schizophrenia, so hallucinations, delusions. And one of the problems is that it doesn't really tackle the negative symptoms of schizophrenia. However, negative symptoms do sometimes show improvement after CBT, even if they're not being targeted. So things like social withdrawal might be better. They might find that some of the skills that they've learnt in the techniques might be able to apply to other areas of their life. Okay, so that's a real summary of cognitive behavioral therapy, looking really at the description and the evaluation of the therapy.